This is Andrew Wolf, and in this video I'm going to talk about cardiac conduction. Now, cardiac conduction is the system that the heart uses to communicate with itself. And by communicating with itself, it's able to coordinate the actions of the myocardium so that the chambers contract in a organized fashion. And this is what allows the heart to work as a pump. Okay, so cardiac conduction occurs because of the specialization of the myocardial cells. And that allows, number one, the myocardial cells are able to generate an action potential. Now, not all myocardial cells can generate action potentials, but some can. And other specializations of the myocardial cells allow these action potentials to travel from cell to cell, otherwise known as action potential propagation. And this can occur because of the intercalated discs that are present in between the myocardial cells, so that ions can freely travel from one cell to the next, allowing the passage of an action potential across the cell junction as if it wasn't there. Now, remember, in the previous video I talked about the concept of the myocardium as being a syncytium, which means the myocardium essentially acts as if it has one big cytoplasm that action potentials can cross. Okay, so the syncytium is actually sort of divided into four parts because we have the different chambers of the heart, and they are divided by relatively thick layer of connective tissue that action potentials can't cross. Okay. Now, remember I talked in the previous video about how some of the myocardial cells lack actin and myosin. So there are some myocardial cells that have no actin and myosin, and these are specially adapted for conduction. Okay, this includes the sinoatrial node, which is a little thin strip of tissue and is about half a centimeter long and a few millimeters wide. And cardiac surgeons are able to identify it pretty readily, and so are pathologists if they know what to look for. And it basically looks like a small square or rectangular piece of pale tissue just below where the superior vena cava enters the right atrium. Okay, and I could identify it if someone showed me where it was, but it's not something I can readily identify. But it is obvious if someone points it out to you. It's a little bit of pale tissue. And then another piece of another section where there are myocardial cells that lack actin and myosin is the AV node. And then there are sort of tracks called internodal pathways that travel to the AV node and also travel across from one intraatrial pathways that travel from one atria to the next. And then there are the Purkinje fibers and ventricular bundle branches. So this is the right bundle. This is the Purkinje fiber that runs in between the atria, and then we have the left bundle branch. And again, these branches are all made up of pathways of myocardial cells that lack actin and myosin. And these pathways cross the connective tissue that separates the four chambers of the heart, and so they are the only pathways that can conduct the action potential. Now, with a normal healthy heart, action potentials are initiated in the SA node, and they start off in the SA node, and then they travel cross to the from the left atrium to the right atrium, and they travel from the SA node through along the internodal pathways to the AV node. Now it's interesting because there is the speed at which they are transmitted across the fibers varies from fiber to fiber. And in the AV node, it's very interesting because the AV node actually slows the conduction of the action potential. So when the AV node is functioning as it should, the AV node actually causes a delay in conduction. And this is just a natural part of the AV node, and it promotes the correct function of the heart. So there is a sort of built-in AV node delay. And it is what causes the typical delay that we see between the P wave, which corresponds to atrial depolarization, and the QRS, which corresponds to ventricular depolarization. So there is a significant delay here called the PR interval, and the PR interval is primarily caused by this natural built-in AV node delay. And for those of you who have worked in cardiology floors or floors with telemetry, you know that this delay is normally about 0.12 to 0.2 seconds. And I don't know of any pathophysiological conditions that speeds up this delay, that makes it less than 0.12, but there are many that make it more than 0.12, where the AV node becomes damaged and actually slows down even more than is normal. Okay, and then their Purkinje fibers also sort of the action potential sort of speeds up again and moves down the Purkinje fibers and across the bundle branches and initiate depolarization of the ventricles. So we have atrial depolarization with a significant AV node delay, followed by ventricular depolarization about 1/10 to 2/10 of a second later. Okay, so let's talk about cardiac action potentials. We learned about action potentials in the nervous system, but let me just review a little bit. Let's say we have a little cell membrane here, and let's just review the resting potential of the cell. So the resting potential of the cell occurs because we have the sodium-potassium pump that exchanges 3 sodium ions for 2 potassium ions, and this is running constantly. And so we end up with a high concentration of sodium outside the cell and a high concentration of potassium inside the cell. And we also end up with this potassium actually starts to slowly leak out of the cell through specialized potassium leak proteins. And these two factors create a situation in which we have more positive ions just outside the cell than there are inside the cell. So we end up with a slightly positive charge outside the cell and a slightly negative charge inside the cell. And if we measure this with a voltmeter, we end up with a charge of negative 90 millivolts, right? Or so. This negative 90 millivolts is actually, this is sort of the average resting potential on cells, but it can vary from cell to cell and from moment to moment. And we talked a little about that in the nervous system, how you can inhibit action potentials by hyperpolarizing the membrane or excite them by hypopolarizing the membrane. So that means that this 90 millivolts can change from sort of moment to moment as the resting potential. So just so you're aware of that, it doesn't have as much of an implication in cardiac cells as it does in nerve cells, though. Okay, so we have this resting potential, and what happens with an action potential is something starts a process that opens up a sodium channel, and sodium rushes into the cell. So we have a little sodium channel here, and we have sodium that's rushing into the cell. And it's just rushing down its concentration gradient, right? Because we have a high concentration of sodium outside the cell. So as soon as you open the gate, that's going to lower the concentration gradient. And what's that going to do? That's going to cause a decrease in the positive charge on the outside of the cell, and an increase of the positive charge on the inside of the cell. And what it does is it triggers a voltage-gated sodium channel to open up. So this voltage gate detects this change in charge, and this change in charge changes the shape of the protein so that it has an open configuration, and this allows more sodium to rush into the cell. And then as we move along the cell membrane, we end up propagating the impulse because we're going to have a negative charge that triggers the next sodium channel to open up. Okay, so then we have this action potential, which is just a change in the from the resting potential of the charged membrane that moves down the membrane because of these voltage gated sodium channels. So let's talk a little bit about, that's kind of a review of the action potentials. And with action potentials with nerves, what we have typically, what causes the initial event to occur is a ligand-gated sodium channel that opens up, and it opens up very suddenly. And then as soon as the action potential passes, the sodium gates change, and the resting potential is restored very, very quickly because potassium rushes back out of the cell to restore the resting potential. So we have another gate here, which is a potassium gate, and potassium rushes out of the cell to restore the equilibrium, and the gates shut. So we end up having a restored equilibrium here. So this all happens very, very quickly with nerves. So let's say we've got, we're starting out with a resting potential of negative 90 millivolts, and maybe we have a threshold of negative 30. So with a nerve action potential, what we have is it's hanging out at a negative 90 resting potential. The sodium gates open up suddenly, and we quickly go up to threshold, and then once the action potential is passed, it quickly is restored to resting potential by the outflow of potassium from the cell. So with a nerve action potential, we have two phases. We have what's called phase 0. I don't know why it's called phase 0 and not phase 1, but that's what it's called. And the phase 0 is fast sodium influx. And then we have phase 1, which is fast potassium efflux. Okay, so we have phase 1 here, and we have phase 0 here with the fast sodium influx, and we have the phase one here with fast potassium efflux. So this all occurs very, very quickly. It's about 2 milliseconds. Now with a cardiac myocyte, we actually have 4 phases. Okay, so here I'm going to draw the cardiac myocyte in red. Now we have the same resting potential, and when sodium gates open, we have a fast sodium influx. It's exactly the same, so that's phase 0. And then we have fast sodium efflux, and that's phase 1. Okay, but then what we have here is a plateau, which is phase 2, and phase 2 is caused by slow calcium influx. So the slow calcium influx is maintaining this difference where the outside of the cell is negative and the inside of the cell is positive, because we have positive calcium ions flowing into the cell slowly. So this prolongs the action potential, so it lasts longer. And then phase 3 is when the closing, this is closing of the slow calcium channels. So you end up with a movement back towards the resting potential. And then phase 4 is just the resting potential. Okay. So the major difference with cardiac myocytes that distinguishes it from nerve cells is this existence of phase 2 and phase 3 with the slow or long the slow or long calcium channels that prolongs this action potential from 2 milliseconds to about 300 or 350 milliseconds. Now, why is this important? Well, what we're not conscious of with our skeletal muscles is every time we have an action potential that goes to a skeletal muscle, here's a little skeletal muscle, it actually only contracts one time, so it causes one twitch. So an action potential equals one twitch. And the reason we're able to sustain a contraction over a period of time, if we're trying to lift a heavy object, it's because there are many action potentials that are coming together in a sort of train, and this causes a sustained contraction. But the cardiac tissue does not have a nervous system to send many action potentials. So it's really dependent on maintaining a sustained contraction with one action potential, and it's able to do this because the action potentials, because of the specialized design of the cardiac myocytes that maintain a long action potential, so it maintains a contraction within that muscle for a significant portion of a second. And that allows if you just had one single twitch in your cardiac muscle, you're not even going to change the shape of the chamber. But if you have a prolonged contraction, that allows the chamber to decrease in size and forcefully expire the contents of the chamber over 350 milliseconds. So these slow calcium channels are a critical element of the of the adaptation of cardiac myocytes in order to have a prolonged and effective chamber ejection. Okay, so this picture here shows a typical myocyte. Now I want to talk about pacemaker cells. And pacemaker cells are the cells that you will see in, if you looked at the cells that are functioning in the SA node. The SA node has the fastest pacemaker cells in the heart, but there are other pacemaker cells in conduction fibers. So we have pacemaker cells in the conduction fibers themselves, we have pacemaker cells in the AV node, and we have pacemaker cells in the Purkinje fibers and in the bundle branches. Cells in these spots also have pacemaker cells. And again, the SA node is the fastest, so it tends to be the one to initiate the action potential before any of the others. But if, as you know, those of you who have any telemetry experience or cardiac experience know that if something goes wrong with the SA node, the AV node will take over. And if something goes wrong with both the SA node and the AV node, or there is a blockage, so the ventricles aren't getting information from the SA node or AV node, then pacemaker cells in these other tissues will take over, but it will be at a much slower rate. For example, the pacemaker cells in the Purkinje fibers and the bundle branches have a rate of about 25 beats per second. So, and these are, if you have a person with a ventricular rhythm, they're going to have a heart rate of around 25 beats per second. The AV node is around 50 beats per second. And as you know, the SA node is, 60 to 80 beats per second. So because the SA node is faster, it tends to be the one in control because it starts the action potential before any of the other tissues can get around to it. Okay, so those are the pacemaker cells. Now, there actually are cells, contractile tissues that also have the potential to be pacemaker cells, but it's generally the conductal tissues that start the pacemaker. All right, so let's draw this little diagram again. Negative 90 millivolts, negative 60 millivolts, negative 30 millivolts, and we'll say that our 30. We'll say that our threshold is negative 60 in this case, and let's say we have a SA node pacemaker cell. Now, if you remember here, the resting potential is flat. If left alone, the resting potential would maintain at negative 90 forever because of continuing action of the sodium-potassium pump and the potassium leak cells and things like that. But with an SA node, there are specialized proteins, membrane proteins, that allow for slow sodium influx. And what does a slow sodium influx do? Well, it slowly changes the resting potential and slowly drops. So we have sodium that is slowly leaking into the cell, and over time it starts to depolarize the membrane. So instead of having a flat resting membrane potential, what we end up with is a sloping resting membrane potential. So as the sodium leaks out of the cell, it starts to slowly move up from negative 90 to negative 60 millivolts. And when it gets to negative 60, then it's going to quickly open up these voltage gated sodium channels, and you're going to end up with an action potential. So you end up with a curve that looks like this. Slowly moving back up towards, and then opening of the fast sodium channels, fast potassium leak, slow calcium leak, and then restoration of the resting potential. So it's the slow sodium influx through these specialized sodium channels that allow this resting potential to slowly work its way up towards the threshold for an action potential. And this is what makes it a pacemaker cell, because this will happen again and again, and it's sort of at a set rate of, every 10 seconds or so. And that will make for a heart rate of about 60 per minute. Now, what changes the rate? Well, when we have a stimulus from the nervous system, if we have a stimulus from the sympathetic nervous system, it will tell the SA node it will cause changes in these slow sodium channels, so that the slow sodium channels become a little bit faster, and it changes the slope of this curve, so that we end up with a situation like this, and we end up with a faster rate. So we have a faster or slower rate depending on the speed of sodium influx through these slow sodium channels. Okay, so that ends my brief discussion of the cardiac conduction, and please let me know if you have any questions. You can put your questions in the YouTube video comments, and as always, please remember to leave feedback. Thank you very much.